Thank you, AIOS, for accepting this course for the first time in AIOS. We have been trying this for many years. Thank you for this time. Thank you, Rajiv, for giving me this opportunity to speak on endoscopic surgery in patients with ocular trauma. I'll be talking about three scenarios, that is open globe injury, intraocular foreign body, post-traumatic endophthalmitis, and also be touching about delayed cases and diagnostic role of endoscopy in patients with ocular trauma. In open globe injury, iris trauma, corneal opacification, hyphema can cause obstruction in the view of intraocular structure. Adequate surgical view is not possible with the conventional operating microscope systems. So we have two options in this scenario. We have temporary keratoprosthesis, and the second is endoscopy. There are studies which have compared temporary keratoprosthesis and endoscopy in these scenarios. The advantage with TKP is the availability of binocularity and stereopsis and possibility of performing bimanual surgery, which may be required in these difficult cases. But there are issues with the temporary keratoprosthesis that you require donor cornea. Longer operating time is required for fixing up TKP, etc. Because of the longer operating time and open sky situation, there are chances of having suprachoroidal hemorrhages, chances of graft failure because of the extensive surgery, silicone oil situation, and inflammation because of the extensive surgery. You may also require the help of anterior segment surgeons sometime, and a watertight fixation of TKP is not possible in some of the cases. Whereas endoscopy requires lesser time, and so there are lesser chances of developing PVR. Severe trauma to the iris, lens, chorioretinal damage, intraocular hemorrhage may lead to proliferative vitreoretinopathy. And this proliferative retinopathy becomes intractable if it is not treated on time. The endoscopy allows exploration of intraocular structures early in the course of the disease, and thereby reducing the chances of development of proliferative vitreoretinopathy and retinal detachment. It requires lesser surgical time, and it is beneficial where TKP cannot be used or graft is not available. Another advantage of endoscopy, especially in trauma cases, is that you don't require to indent in endoscopy procedure. And in these patients of trauma, because the wound is not stable, it is difficult to indent these patients in the conventional system. There are some issues with endoscopy. As we have discussed in the earlier talks also, the bimanual instrumentation is not possible as one of your hand holds the endoscope. And in trauma cases, sometimes bimanual instrumentation becomes very, very, very much needed. Lack of stereopsis and binocularity is an issue. The view is two-dimensional and it is not a three-dimensional view, so the surgery becomes a little difficult. There is shifting perspective. You are operating and seeing in front of seeing the view in front of you on the screen. There is difficulty in depth perception, as we have already discussed. The view is small. The view is tunnel-like. Either it is 125 or 145 degree based on the type of endoscope that you are using. Another irritating issue is that the focusing is controlled by an assistant. When you're doing surgery and something is not focused, you get irritated and you have to depend on the assistant for a better focusing. Rotation of endoscope causes rotation of field of view. And all these things make this endoscopic surgery little difficult than the conventional surgery. So for all these things, you need to have some time. You require a learning curve is required. And the another issue is the cost and availability of the equipment. But definitely, endoscopy allows procedures that are not possible with microscopic view. Intraocular foreign bodies are frequent in ocular trauma, and they need early intervention because of the toxicity issues, siderosis, chalcosis, and also the chances of infection are more when there is foreign body inside the eye. Delayed surgery may also cause encapsulation of foreign body, which makes the subsequent removal of the foreign body difficult. And endoscopy allows early intervention in these cases, and endoscopy is a valid alternative for foreign body removal in these patients. Now, in the scenario of post-traumatic endophthalmitis, we all know that EVS study has confirmed the benefits of early vitrectomy in endophthalmitis. Anterior segment opacities due to trauma can often limit the standard vitrectomy for endophthalmitis in ocular trauma patients. Endoscope is useful in such situation to perform early vitrectomy. Endoscope is also helpful in visualizing anterior structures like ciliary body, which often is covered by inflammatory membranes, and that leads to intractable hypertony in these ocular trauma patients who have traumatic endophthalmitis. Now, another important role of endoscopy in patients with trauma is the ultrasound. We all know that ultrasound has varying sensitivity and specificity in picking up IOFB and retinal detachment. Dr. Mudit has already shown the pictures. Endoscopy ensures immediate diagnosis on table, and unnecessary procedures like keratoprosthesis can be avoided. Prognostication of final visual acuity is very important dimension for the management in ocular trauma. Endoscopy, by allowing the direct visualization of the intraocular structures, give a better prognostication to the operating surgeon as well as to the patient for the counseling purposes. Avli Prasad has done a surgery in that, and they also add endoscopy allows prognostication of cases with posterior segment pathology following trauma. Appropriate prognostication avoids surgery in poor prognosis cases, and in appropriate cases, endoscopic approach allows for a resolution of corneal edema and avoids the need for unnecessary keratoplasty. I'll show you two small videos. First is a metallic foreign body at the ciliary body. This was a 41-year-old male patient who sustained injury with the iron particle. Vitrectomy for intraocular foreign body removal was done 18 months back at some other center, but foreign body could not be removed. This patient had secondary glaucoma, total cataract, siderosis. A CT scan of orbit was performed that revealed a foreign body lying at the ciliary body, anterior ciliary body. This is a small video showing the removal. Cataract surgery was performed before the procedure in an attempt to visualize the foreign body through the conventional system, but the foreign body could not be visualized. So endoscope was used to localize the foreign body. These are the cut edge of the vitreous fibers, which are appearing white. This is the optic nerve, posterior pole, and I'm trying to locate the foreign body with endoscope. This is the foreign body lying at the anterior ciliary body. Now, with the help of intraocular magnet, I'll try to lift this foreign body from the surface of the ciliary body. But because of the adhesions, the foreign body is difficult to detach from the ciliary body surface. Now, with the help of vitreous cutter, the adhesions are removed. And after the removal of these adhesions, the foreign body is lifted with the help of intraocular magnet. But again, this foreign body is stuck at the small sclerotomy site. This sclerotomy site is enlarged. In this process, the foreign body falls again on the posterior pole, and this foreign body again lifted with the help of intraocular magnet and removed to the sclerotomy. This is another scenario which we have already discussed, is the role of endoscopy in diagnosis. This was a patient where endoscopy was performed in opaque cornea. This was a trauma patient referred to me for evaluation of posterior segment for performing keratoplasty procedure. This patient, this is an endoscopy picture. You can see the retina is attached. The disc looks okay, though evaluation of disc sometimes is not possible. But the overall retina in the posterior pole looks healthy. There are some fibrotic scars in the periphery. So this patient can be taken up for a procedure, although with a guarded prognosis. This patient was operated by Dr. Abhishek Kothari in Jaipur. This is the PK pictures, and this is the actual fundus picture after the surgery. This patient regained vision of 6/12 after the final procedure. So endoscopy is also a very helpful tool in assessing the posterior segment in these trauma patients. In conclusion, Endoscopy has certain advantages over TKP and the conventional surgery. It allows earlier intervention. It requires lesser surgical time, so there are lesser complications, provides more time for the surgeon to find a useful corneal graft for implantation. Postoperative inflammation is less severe than after endoscopic surgery than after the TKP implantation. Endoscopy has certain disadvantages and difficulties and issues. The learning curve is quite steep. There is a difficulty because of the lack of stereopsis, limited field of view, and difficulty in performing bimanual surgery. High cost of the equipment is also an issue. But endoscopy allows procedures that are not possible with microscopic view. So endoscopy is a very useful tool for armamentarium in the VR OT. Thank you. I have a very small video of about 3 minutes where I am showing us innovation which is cost effective and yet very efficient in performing endoscopy in posterior segment surgery.
Endoscopy is undoubtedly a versatile tool for diagnosis and treatment of complex vitreoretinal conditions. I think there are two main reasons for endoscopic surgery not being popular. The first is cost of the equipment, and the second is insufficient image quality because of the outdated components. I am presenting a novel, cost-effective, yet efficient modified portable camera endoscope for VR surgery. Commercially available endoscopy system has a base unit and a monitor. The base unit has an illumination source, video camera, an interface for the fiber optic endoscope, and optional laser photocoagulator. I present a feasible, cheaper, but more efficient approach for endoscopic surgery using a modified C-mount portable GoPro camera. The interface for the endoscope is attached to a GoPro 7 Black camera through a C-mount. Light source can be a separate LED light source, or a vitrectomy light source can also be used for illumination. This is the C-mount at GoPro camera, and the endoscopic interface is connected to the C-mount. HDMI cable is inserted in the micro HDMI port of GoPro camera and connected to a HDMI interface of a monitor. This is the touchscreen panel for the controls on the back of the camera. Your GoPro camera endoscope is ready for use now after connecting fiber optic endoscopic cable. You can use a separate LED source or a light source of vitrectomy machine and a 4K monitor for even better visualization. This is the endoscopic view with this new endoscope using a 23-gauge fiber optic cable. The resolution and illumination both are better than the commercially available system. If you connect this endoscope to a 4K monitor, the visualization will be even better. If you compare with the commercially available system, the modified GoPro camera has much higher resolution, up to 4K, much higher light sensitivity. It has facility of digital zoom. This is not a bulky system. It can be used as a mobile device. Video output is not the older S video, but an advanced HDMI output, and all that at less than 1/10 of the cost. This article in Retina was a source of inspiration for developing this useful device, that is endoscope for all. Thank you.